the GTG that we'll be covering will be on the preventing entry-related gynecological laparoscopic injuries. So, if we talk about the entry techniques, there are two types of entry techniques. One is a closed, which is, it actually depends whether you're going for closed or open. Depends on the expertise of the laparoscopic surgeon. So closed is when you're doing it blindly using a Veress needle or a direct trocar. So in this you hear two audible clicks. So first one is the rectus and the second is the peritoneum. And open is when you give a nick under vision, you enter. Then regarding the pressure, do we have any student with us? Okay. So entry techniques, what should be the pressure to safely enter the, when you are entering, what should be the pressure of the primary or the secondary trocar? So the pressure should be 20 to 25 millimeter of mercury. And once you have entered and you're performing the surgery, then the pressure should be 12 to 15 millimeter of mercury. Then what is Palmer's point? So there are various types of laparoscopic entry points. So most common of these is the umbilicus. Then there is a Palmer's point, which is basically if 3 centimeter below the left costal margin in the mid-clavicular line. So this is the Palmer's point, which is the alternative point of entry. The other is Li Huang point, which is midline. If you join a line from Xiphi sternum to the umbilicus, the midpoint of it is Li Huang point. The other points are you can either enter to the posterior fornix or the lower in the mid-clavicular line. So then how many attempts you can make while you are inserting the Veress needle? So according to the guideline and according to RCOG, if you are doing a blind insertion through a closed technique using a Veress needle, and there are 2 unsuccessful attempts, then in those cases, you should go for either open Hassen's technique or the Palmer's point of entry. And in case, like also if the patient is obese or if the BMI is very low, in those cases, again, you go for Palmer's point or open entry. Then again, this is an important exam tested recall about the risk of the adhesions. So if there is no previous surgery, the risk is 0.68%. If there is a previous laparoscopic surgery, then the risk is 1.6%. For previous transverse laparotomy, it is 19.8%, and previous midline laparotomy, it is 52%. Now coming over to the next guideline on the vascular injuries during laparoscopy. So in order to avoid the vascular injury, the safe zone, if we talk about, is either if you insert it within 1 centimeter of the midline or more than 8 centimeter. 1 to 8 centimeter is an unsafe zone. Then again, there's something which is called as Tinley's yellow island, which is when you draw a line from the umbilicus to the ASIS, the junction between 2/3 and 1/3 is a Tinley's yellow island. It is again a safe zone. If you talk about what is a safe zone, so the answer here should be all of the above, which is less than 1 centimeter from the midline or more than 8 centimeter. More than 2/3 along the line joining the midline and the ASIS. So 2/3, 1/3 if you divide it. Then Tinley's yellow island. So all of these are the safe zones. And the most common vascular injury which occurs during laparoscopic entry is like particularly when you are inserting the secondary trocar, it is inferior epigastric. Then, in order to avoid vascular injuries, what should be the position while you are inserting the trocars? So, ideally, when you're performing a laparoscopic surgery, during insertion of the trocar, the patient should be supine. Why? Because it has been seen that in supine position, the aortic bifurcation, it ranges from 5 centimeter capillard to 3 centimeter caudal. However, in Trendelenburg, there is 2 centimeter difference. Is there? It is less. It is only 3 centimeter capillard and 3 centimeter caudal. So chances of aortic injury is much more if you are inserting in Trendelenburg position as compared to when you are inserting in supine position. It is 33% versus 11%. So this you have to remember that while inserting the trocars, the patient should be supine, and while you are performing the surgery, you can make the patient Trendelenburg, because if you're performing the pelvic surgeries, you want the bowel to move up. That's why you make the patient Trendelenburg. Then moving on to the last guideline, which we'll be discussing today. It is about urinary tract injury in the laparoscopic gynecological surgery. Now, if you talk about the most common visceral injury related to laparoscopic pelvic surgery, it is bladder injury with an incidence of 0.02% to 8.3%. And most of these injuries, they occur when you are dissecting bladder from the cervix. This is when you are doing surgeries for a previous scar. If you're doing surgeries for in a primary patient, then it is during entry actually, or opening the abdomen. Then most common site is midline above the intertrochanteric bar. And this again, an important exam tested question, that only 50% of the bladder injuries, they are identified intra-op, 50% are still missed. And the causes, the risk factors for urinary tract injuries, anything which can lead to adhesions like endometriosis, cancer, or adhesions from previous surgery, or severe genital organ prolapse, or if there is obesity or pregnant uterus. Then how do you manage these? So bladder injury, they can be repaired either by a gynecologist or a urologist, and the sutures that you use is 20 or 30 absorbable. Ideally, it should be a non-locked repair with sutures which are placed 0.5 to 1 centimeter apart and 0.5 to 1 centimeter lateral to the cystotomy angles. And if they're involving the trigon, then you have to put the stents, and patency of the urethra and ureter should be confirmed following the repair. And repair should ideally be watertight, and it should be leakage proof, and it should be tested once you have inserted the suture by inserting the dyes, like you can use methylene blue or indigo carmine. And once you have done the bladder repair, you have to put the catheter for 2 weeks. And before removing the catheter after 2 weeks, you also have to perform retrograde cystography in order to ensure that it has been completely repaired and there is no further leak. Okay. And in case there is a leak, then you wait for another 1 week. Now coming over to the last topic for today, that is about the ureteric injury. The incidence is less than 1 to 2%. And in case it is you're doing laparoscopic surgery for deep infiltrating endometriosis, then the incidence is much higher. It is around 21%. And the most common site where ureteric injury occurs is at the pelvic brim and lateral to the cervix. And 33, it is only like I told you about a bladder injury, 50% of the bladder injuries are recognized intra-op. However, if you're considering about the ureteric injury, only 33% are recognized intra-op. And the most common type of ureteric injuries are transection. The other types include angulation, crush injury, ligation, thermal injury, laceration, or resection. Now, how do you manage? So, as I told you, the most common is transection. So, in case it is transection, then you have to see which part of the ureter is involved. You divide the ureter into 3 parts. So, if it is in the upper third of the ureter, then you do ureterostomy or end-to-end anastomosis. In case it is middle third, then you either do ureterostomy or you do transureterostomy. So what is transureterostomy? Where perpendicularly the ureter is sutured with the remaining part. If it is at the lower end, then you do ureteroneocystostomy, or you do Swas Hitch or the Boris flap. In case it is minor crush injury or needle injury, then you can manage these patients conservatively, provided that the ureter's integrity and the viability have not been compromised. In case it is obstruction, then the best thing is you do ureteral stenting. And for thermal injuries, is again you have to do stenting in order to avoid stenosis and urine leakage during heat. Then when you are performing the ureteric repair, you have to ensure that it should be watertight, tension free, and ideally it should be spatulated or fish mouth. And you should take all precautions because there are vessels which are running around the course of the ureters. So dissection should be very meticulous, and we should avoid devascularization of the ureters. And also, like when you're debriding the ureter, you should avoid shortening of the ureter, and ideally, so that adequate repair is there. There is no tension on the ureters. And ideally, you should use absorbable intermittent suture and avoid using too many sutures. And after suturing, you put a stent in order to avoid any kind of scarring or stenosis. Okay, so this was all about ureteric injury and other laparoscopy associated injury. In case you have any questions, you can post it on in the comment section. Thank you so much for your time. Hello.
Recording stopped.
Yeah, it is done. I think none of the students joined. Were they supposed to join in this? Hello.
Hello, ma'am.
Yeah, so it is over. The session is over. So none of the students joined. Were they supposed to join in this?
No, ma'am. Actually, this is live stream in YouTube. On YouTube, ma'am.
Okay, so live stream people joined, right? Okay, then